It's my pleasure to invite my co-chairman and well-known Professor Amos Korchin from Israel to present the disease course modification in Parkinson's disease.
Thank you very much. Thank you very much, Professor Bajanaro, for the introduction. And I think over the past couple of days, you've heard a couple of talks already about Parkinson's disease and about the therapy of Parkinson's disease. And there are more lectures on this topic coming soon. But all of this relates to the issue of symptomatic therapy. So we know that Parkinson's disease is a progressive disease, and we know pretty well how to treat these patients symptomatically, although we always have time for improvement. But the question is really how can you ameliorate or improve the prognosis of these patients? How can you change the disease course of this neurodegenerative disease? So in order to do this, I will try to summarize my thoughts about it. It's important, I was told by Professor Moroshano and Professor Bornstein to say what are the goals of each talk. So the goals of my talk, or the take-home messages, are the following, and this is what you should learn. If you know it already, you can leave and have coffee outside. What I'm going to try to convince you is that Parkinson's disease is not really a disease, but rather a syndrome, that this disease is a result of contributions by several genetic and environmental factors, and this is the result of the phenotypic convergence. There are several metabolic abnormalities likely to cause this neurodegenerative process, and we have to identify these in individual patients in order to change the future of these patients. So what do we mean when we speak about Parkinson's disease? What is Parkinson's disease? Can anybody define Parkinson's disease for us? Come on, after being here for so long, you don't know how to define Parkinson's disease? I can't believe it. Will someone please volunteer and tell us what is Parkinson's disease? What is the definition of Parkinson's disease? Come on. Or I will nominate someone to define it for us. Don't fall asleep. It's still morning. Well, let's ask somebody from the faculty. Fabrizio, what is Parkinson's disease for you?
It's a syndrome. It's a complex syndrome characterized by bradykinesia and other abnormal movements such as instability, tremor, rigidity, and other symptoms. It's actually a syndrome because we don't know exactly the cause of Parkinson's disease, but definitely the majority of patients suffer from an alpha-synucleinopathy. So it is an alpha-synucleinopathy.
All right, so here it is, more or less what you said. So this is something, the clinical definition, and we'll leave aside the pathogenesis, which you mentioned, what you talked about. We'll come to this later. But the clinical definition is this one. So it's the definition of the phenotypic thing is, of course, of a syndrome, not of a disease, as you have rightly correctly said. So this is, as far as we understand, this is how we define Parkinson's disease. If somebody has this, we say this is Parkinson's disease. But we also, and Fabrizio also alluded to this, there is also the underlying pathology, which we assume occurs in these patients. So what is the pathological definition of Parkinson's disease? Let me ask my co-chairman, please, Professor Bajanaro, what is the pathological definition of Parkinson's disease? So this is the correct answer. Actually, there is no pathological definition. There is none. So we know what we see in the
Yes, it is a syndrome. Of course, there is no pathological definition.
No, but okay, but we spoke about Parkinson's.
There are some common aspects on pathological background, but it's not a. When you have a pathological definition, you have a disease. We speak about syndrome.
All right. So there is no pathological definition. So there is pathological definition of Alzheimer's disease. The pathologists sat around and decided this is what we call Alzheimer's disease. In Parkinson's disease, they never came to a conclusion. We know that there are synuclein deposits, as Fabrizio has mentioned. We know that we call them Levy bodies sometimes, if they're in the cell body. But these are not the definition of a disease, because sometimes we see these changes without having clinical manifestations. So it's not. There is no agreed upon pathological definition of Parkinson's disease. Now, to go back to the clinical part, so we know that there is quite a lot of heterogeneity in Parkinson's disease. Some patients, we say, are tremor predominant, some are akinetic rigid, some have a postural instability or gait disorder, and so on and so on. There are a couple others as well. So what do we mean when we speak about clinical heterogeneity? Is one of them related to a different pathogenesis or to a different something else, modifying factors? What is it that makes one person tremor predominant and another akinetic rigid? Of course, this is important for us as clinicians when we try to treat the patient symptomatically. But to look at the basis of this, we don't understand this. So are these different disorders or what? So there is clinical heterogeneity. There is also genetic heterogeneity, as we know. Not all patients have the same genetic background. In a few cases, this is due to Mendelian dominant or recessive gene mutations. So these are numbered here. There are a couple more, perhaps. So this is for the Mendelian familial cases, but these are, of course, a small minority of the group of patients with Parkinson's disease, and most patients have a sporadic disease, and we look at the sporadic diseases and we try to find out whether there is a genetic background to them. So for this we use GWAS, and GWAS identifies many candidates. Each of them has a small contribution. So none of them has a predominant role for the majority of patients who have Parkinson's disease, the clinical syndrome of Parkinson's disease in the sporadic way. We also know that there are environmental factors that are associated. So we all know, if you ask any student even who comes to the neurology clinic and to study neurology for a couple of weeks or 2 months, what is it? And they come up and say, we know that it's more likely to be age-related. I mean, we don't see kids with Parkinson's disease. We don't see young adults with Parkinson's disease. The frequency of the disease increases with age, so age is an important factor. Males are more affected by Parkinson's disease. Sometimes toxin exposure is related to it. Head trauma is definitely a cause, one of the contributing factors. And we also know that there are protective factors, the most important of which is smoking. So not that we recommend smoking, but people who smoke are less likely to develop Parkinson's disease. And we don't understand really what is the mechanism underlying any of these causative or protective factors, how they are associated with the disease. So given all this, that there are so many factors, some genetic contributions of small amount, and some environmental factors of small amount, which all lead to a common phenotype, which we call Parkinson's disease, we must accept that this is due to what we call phenotypic convergence. So there is the same phenotype which results from different causes. And therefore, I think that it's important to look at it and ask ourselves a more perhaps philosophical question, and this is whether Parkinson's disease is really a single disease. So we all agree, we should all agree, if we see a patient like the patients that were demonstrated yesterday, that some of them have Parkinson's disease. But what is it? Because of the clinical, pathological, and genetic heterogeneity, maybe it's not one disease, what we call. And this, an old question, I asked it in the previous millennium already, the same question, whether Parkinson's disease is one disease entity or many. And before me, there was my friend Donald Kahn, who asked the same question. But if we look at it more critically, we can ask ourselves, is Parkinson's disease really a disease? What do I mean when you ask whether Parkinson's disease is a disease? What is a disease? What do we mean by a disease? In order to answer or to illustrate my question, I will ask to illustrate this, I will ask, is hepatic cirrhosis a disease? So who thinks that hepatic cirrhosis is a disease? Please raise your hand. Who thinks that hepatic disease is not a disease?
It's not a disease.
And I'm sorry to say that most people here do not think at all. Once again, who thinks that Parkinson's disease is a disease? All right. Who thinks that it's not a disease? All right. So, Stefan, why do you think that Parkinson's disease, that hepatic cirrhosis is a disease? Okay. And Fabrizio, why do you think that it's not a disease?
Cirrhosis? Because it may come from a different aspect and then different etiopathogenesis.
Okay. So I agree with Fabrizio. And of course, what we call cirrhosis, hepatic cirrhosis, I mean, there's only cirrhosis. There is no cirrhosis of other organ. Hepatic, always hepatic. So is cirrhosis a disease? No, because it can result from many factors. It can result from hepatitis, it can result from alcohol abuse, from whatever, many, many causes, many more than are written here on this list. It's important to differentiate them. So in an individual patient who comes to the medical department with cirrhosis, the clinician should be able to say whether this is due to one cause or another. And this is very important also because if we want to eliminate cirrhosis, we have to decide which type of cirrhosis do we want to eliminate. If we want to eliminate cirrhosis due to hepatitis, we can immunize people against hepatitis. If we want to immunize people from having alcohol abuse cirrhosis, we should recommend to them to move to Saudi Arabia. There, by law, you are not allowed to have hepatic cirrhosis, alcoholic cirrhosis. So this is clinically important. But, as Stefan has said, there is some commonality here because all these cases of hepatic cirrhosis have the same clinical manifestations, have the same biomarkers like bilirubin or transaminase, and have the same pathology. So having the same pathology, same clinical manifestations, and same biomarkers do not make it a disease, but make it a combination of different disorders which have the phenotypic convergence. So a disease actually does not exist. There are no diseases, except in our brain. Disease is an abstract concept. And in order to identify a disease as such, for me, I have to understand what is the pathogenesis. And therefore, the pathogenesis of liver cirrhosis caused by hepatitis is different from liver cirrhosis, different disease than that caused by alcohol abuse. So these are different disorders. based on the pathogenesis. So the important thing is the pathogenesis. So why do we consider Parkinson's disease a disease? So here we find ourselves in problem, not because of the clinical features, not because of the etiology, not because of biomarkers, not because of pathology. We went through this. So none of this fulfills this as a disease. However, there is a big difference between cirrhosis and Parkinson's disease. Because in cirrhosis, I told you that a good clinician will be able to identify the cause of cirrhosis in that patient. In Parkinson's disease, this is not the case. In the sporadic form of Parkinson's disease, there are many factors that contribute that we mentioned before. All these environmental and genetic factors for the sporadic disease, each contributing a little bit, and the combination is what causes the syndrome of Parkinson's disease. And this combination is different in one patient from the other. There are no two patients in the world who have exactly the same combination of factors leading to the phenotype that they manifest and which we call Parkinson's disease. So for me, Parkinson's disease, again, I speak about the sporadic form. I define it as a complex progressive neurodegenerative disorder characterized by brain atrophy and deposits of synuclein, of course, which is caused by heterogeneous combination of environmental and genetic factors. And because of this complexity and the etiological heterogeneity, it is not a disease in the classical sense of the word. And there are several pathogenic pathways which may lead to this final common phenotype. So sporadic Parkinson's disease, small contribution by many genes, and small contributions by many acquired factors, leading to neurodegeneration of the cells that you know about, which will lead finally to the PD phenotype. And therefore, it's a big question in my mind whether we can have a single encompassing definition of Parkinson's disease, a definition of Parkinson's disease. So if we don't know if there is no common mechanism to all of them, how can we find a disease-modifying therapy? In order to define a disease-modifying therapy, we have to know what is the cause, or maybe not. So maybe we should think for this out of the box and think about, and I will take these two approaches, modern approaches of genomics and metabolomics. And in order to look at genomics, let's look again at the genes associated with PD. So we already mentioned the genes which are associated with Mendelian form of Parkinson's disease. But if we look at them, at all of them, we can say that this can be grouped into 4 groups. Those genes again, I'm speaking about the Mendelian causes. Those genes are associated with oxidative stress, those that are associated with protein handling, those that are associated with inflammation, and those which are associated with autophagy through the lysosomal dysfunction. And these are different ones, and I'm not the first one to group them this way. And this is very important. Because this is what we think is happening. So mitochondrial dysfunction is associated with these genes, DJ1 and PINK1, and ubiquitin proteasome system dysfunction with Parkin and UCHL1, and inflammation, maybe synuclein duplication or mutation, lysosomal dysfunction in GBA, and so on, and some are not so clear. It's very interesting that when we talk about the animal models of Parkinson's disease that we use, we also know about mitochondrial toxins and ubiquitin proteasome system, which cause the same phenotype which we use for this. So maybe it is right to, when we go back to the different forms of Parkinson's disease, to say that some are associated with proteasome dysfunction and other with mitochondrial dysfunction. which lead in the proteasome dysfunction to protein mishandling, autophagy, neurodegeneration, mitochondrial dysfunction through oxidative stress and mitophagy, again to mitochondrial dysfunction, leading to Parkinson's disease in different pathways. So if these are different pathways, maybe we should say that these are different disorders, different diseases, which we can call PD type A or type B or whatever we ask. Why is this so important? It's important because if we talk about mitochondrial dysfunction, about this on the right, then this means that this is due to oxidative stress, and we know how to deal with oxidative stress. We don't know quite well already by now how to deal with protein mishandling. So how do we deal with mitochondrial dysfunction? There is this old drug that you've heard of, Q10, and because of the assumption that some patients with Parkinson's disease have mitochondrial dysfunction, this has been an old finding already, people try to treat it with coenzyme Q10, and it was not very successful. Why was it not very successful? We don't know. Maybe because only some of the patients had mitochondrial dysfunction. Maybe if we would have treated only this subgroup of patients with Parkinson's disease who have important mitochondrial dysfunction, it would have been more helpful. But since we treated in the same group also patients who have proteasome dysfunction or lysosomal dysfunction and not mitochondrial dysfunction, this was only a minority, and therefore the effect was not sustained and not seen. So this is why I think we should understand what is the mechanism. Today, we can identify who are the patients who have mitochondrial dysfunction. In Parkinson's disease, again, stories that are in the field for 20 years or so, or maybe even more, have identified mitochondrial dysfunction in some cases of Parkinson's disease. So if we would treat only these patients who have a different disease from those patients who have the same clinical phenotype due to another mechanism, then it could have worked. So the future directions are that looking at upstream markers like the genetic mutations and polymorphism is unlikely to yield a useful target for intervention against the sporadic form. And we see this also already in Alzheimer's disease, where we know about the existence of ApoE, epsilon-4, as a risk factor for Alzheimer's disease for now 25 years, and we did not come with any solution. So identifying the genetic course, the upstream, the most upstream marker, has not yielded anything else. And looking at downstream markers like the apoptosis, this is just too late. So we should aim at the intermediate pathways, markers, and these are different in individual patients. In some patients it is one mechanism, in others it's different. And we've done it to some extent. So for example, you've all heard about vascular Parkinsonism. So here, there are vascular risk factors leading through small vessel disease to white matter changes, and then to the phenotype of vascular Parkinsonism. So in these cases, we know that those patients also do not benefit clinically from symptomatic drugs, and we have to give them drugs which are more related to the pathogenesis, which are the vascular changes. So as I said before, here are the take-home messages that Professor Moroshano and Professor Bornstein wanted me to tell you about. And I hope I convinced you. Parkinson's disease is not a disease, it's a syndrome. The clinical syndrome is a result of phenotypic convergence. The idiopathic Parkinson's disease is a result of contribution by several genetic and environmental factors, and different metabolic abnormalities are likely underlie the neurodegeneration. And we have to identify these different processes. And this is something that I already published. So those of you who want to read more, this has been published in BMC Medicine a couple of years ago. And I would also use this opportunity to invite you to CONI, the Controversies in Neurology meeting that several of the faculty here have contributed to in the past and are likely to come to Warsaw in March of next year. Together with Jarek Slavek, we organize this meeting, and I very much hope to see many of you there. There are flyers outside, and there are grants to people coming from developing countries. So those of you who want to join, please register, and you'll enjoy the meeting. Thank you very much for your attention. And if you have, is there time for questions?
Thank you, Professor Korchin. Yes. Are there any comments or questions to Professor Korchin's presentation?
Fabrizio wants to say something.
No, I think you're right for the syndromes, and definitely today many people are convinced that this is the case. This is a syndrome, but definitely within a syndrome we start to identify some cluster of patients with the more specific cause of PD. So now we can discuss about I know that you disagree about the fact that alpha-synuclein could be a prion, but definitely it's there. So alpha-synuclein is one of the cause of PD. The genetic forms, they actually develop in other, the GAD, which is now becoming such an important aspect of the disease. So I think you're right. I mean, we should actually address different treatment for different patients. Still, most of the symptomatic drugs that we use every day, they work for the majority of the patients. So there is a common feature of PD that eventually respond to symptomatic treatment, despite the origin is different from different patients. What do you think?
So no question. So what you say is that firstly that most patients respond to dopaminergic drugs, and this we know. This is part of the definition of the syndrome that we agree occurs. You think that this is related to synucleinopathy, and we all agree that there is synucleinopathy there. Whether synuclein deposition is the cause or a manifestation, we still don't know. This is one of the questions that we are going to ask in CONI. One person would say that this is a cause, and another would say, no, this may not be the cause, but just a reflection of the pathology. Some neurons reflect to stress by depositing synuclein. Of course, patients who have synuclein mutations have what we call Parkinson's disease, but this is a different disorder, because in these cases, in the cases where there is alpha-synuclein mutation or duplication, this can be cured completely very easily by just blocking this gene. And now with the modern techniques, it is easy. It's done already in animals. Next year or in 5 years, it will be done in humans. If you have a person who was born with alpha-synuclein mutation, you can eliminate this gene, silence this gene, and the person will not develop the disease later on. I mean, this will be done. It's already almost done in Huntington. It will be done in patients with Parkinson. But this will not be helpful to the patients who have the sporadic form of the disease, which therefore it is a different disease, which will be treated differently. If we want to go to individualized, to personalized medicine, this is the lesson, that those patients who have LRRK2 or GBA mutations will be treated differently than patients who have alpha-synuclein mutations, and those patients who have sporadic forms, this is a different story altogether. So in Israel, among the Ashkenazi Jews, 1/3 of the cases, 1/3 of our patients have a mutation, either GBA or LRRK2 mutations. And this will not be treated in the same way. One will be treated one way and the other in a second way. So this is the lesson, that Parkinson's disease is a syndrome. There are many causes that contribute to this. sometimes, rarely, single causes like alpha-synuclein mutations, mostly a combination of risk factors, and it should be identified, and we are able to identify who are the patients who have mitochondrial dysfunction, are the patients who have lysosomal dysfunction, and each of them will need to be treated differently. Thank you for your attention, and if there are more questions, then during the coffee break, I'll be happy to answer.
Thank you, Professor Korchin.